Okay, so we're gonna go over ARDS, just some of the stuff. I know you guys didn't complete it, so I'll still go over the things that you need to know. Um, and we'll go over some of the vent modes because I know that those things are confusing for you. But I'm going to give a little preface just because I feel like a lot of you guys think that you have to memorize the vent modes. You do not. I feel like our entire class studied all of the vent modes and everything, and she did not ask us a single question about vents. And I wouldn't be surprised if she does the same. I think she only asked about one, and I'm pretty sure it's PCIRV. So pressure control with inverse ratio. And I think she just asked us um, like what is the ratio going to be type of question, or like what is true about PCI or V. And it's like, okay, well, it's pressure control, and then it's you have an inverse ratio with that too. So we'll talk about that, what that means in a second. But it was super basic, and I don't even remember that question. I was talking to a friend about it, and she said that we had that question on an exam, but I don't remember it. It might have been on a quiz, but she will not ask you like, what's this one, what's this one, what's this one. Really, all she will do, and we'll go through these practice questions. Some of them. I'm gonna let you guys do the rest of these on your own, but I do have like the answers on here. She will more of just put like PRVC like within the mode, assist control within the mode, SIMV, volume control. So it's like even if you don't know what they are, really all you're going to be doing is following this chart right here. So I don't think she asked anything. I don't think you have to know everything. I only knew what I know is like what I'm going to tell you. And that's all I knew going into it. And I thought that I'm glad I didn't overthink that. So that's what I would say for that. Don't overthink these. So when I go through it, don't feel like, oh, I need to understand 100% what she's talking about. No, I'm just going to tell you the basic stuff and hopefully give you a clearer image of what that looks like. But I do not expect her to ask you these things because, again, this is outside of your scope a little bit. My one of my friends is an RT, and she was like, I don't know why you're kind of explaining these things because in the hospital, if you're working in the ICU, your RT will be changing the stuff for you. You can't be doing stuff like that. So keep that in mind. But at the same time, you know how Mandiola is, you never know. She might ask these things. But again, I wouldn't harp on this type of stuff as long as you understand the basics of it. Okay. So we're gonna go over arts for probably like 5 to 10 minutes, and then the rest of the time is just gonna be talking about modes. So ARDS, obviously this is a part of sepsis. So remember, like last semester we were talking about sepsis, we were talking about like DIC, ARDS, and then MODS. This semester you'll be learning about all three of them, which is um, kind of funny because I feel like they mentioned it in earlier semesters, but this is like the critical care semester, right? So with ARDS, the one things that she will ask you are basically the entire thing highlighted in green. Like basically with that, and then some of the stuff highlighted in purple, but again, you guys haven't gone over that some of that stuff yet, so I'm kind of gonna wait. But um she just wants you to know the definition of ARDS. So exactly the um, timing. So within 1 week. So within 7 days or before. So if she tells you on a select all the apply, what is um, what supports the patient's diagnosis of ARDS to the physician or to the nurse or whatever. If it says they've had symptoms within 5 days, you select that one. If it's within 9 days, you don't select it. Within 7, you select it. If it's within 1 week. So timing, it's within 1 week. The next one is the hypoxemia. So we'll get into that in a second, but we're going to move on to the next one. So a checks X-ray or a CT scan showing bilateral opacities. So that one, fully have to know that one too. She'll ask you that. It'll be basically on a select all the apply, I'm pretty sure. So if they don't have that, that doesn't support that. So it's pretty obvious. So far we have 1 week CT or X-ray showing that, and then the origin, right? So it wouldn't make sense. This is a respiratory issue. It's literally called acute respiratory distress. So it wouldn't make sense if this was a heart issue that started this problem because now that's caused by a cardiac issue, right? If we're having CHF and we're having shortness of breath from that, you got to fix the heart problem. It's not, you're having hypoxemia because of the heart, not because of a respiratory problem, right? So if it's a respiratory thing, then you select it, right? If they say respiratory origin, and she'll kind of tell you like pulmonary, something of like a pulmonary origin, right? So that makes sense. If it's not, if it's cardiac, if it's fluid, if it's something else, you don't select it. So those are the three so far. And then the last thing is the hypoxemia. So if she says the patient has hypoxemia, you're going to select it. But usually what she'll do is she'll just ask you for the actual range. So if she says like above 3, like the PaO2 slash FiO2 ratio is above 300, well, remember above 300 is normal. So that's not one of the definition or criteria for it. So she will ask you this 100%. So you have to know all of these things. If you have to memorize it, you memorize it. But really, the one big thing too is understanding the ratio and how to do that. So it is kind of memorizing the values, right? Anything above 300 is normal. Anything between 201 to 300 is mild. Anything moderate, 101 to 200. So really all you have to remember is if it's above 300, it's normal. If it's below or equal to 100, it's severe, right? And then going up from there. So she will ask you that. She'll ask you that in these questions. So we'll go over that in a second. So for these ones right here, I will send you guys this PDF in the WhatsApp chat. But I just wanted to kind of show what that's going to look like. So she will give you, and she might even give you a whole paragraph at the top and be like, a patient comes in with shortness of breath. They're having problems breathing. Eventually, they're admitted to the ICU. Ends up getting intubated. Here's their modes and their settings. Here's their ABGs. Here are their vital signs. And it literally is like a whole case study, right? Kind of something like you would see on ATI. The only thing is she's asking you for the PF ratio is to look at the FiO2 and to look at the PaO2. In addition to the ABGs, she'll also give you like the bicarb and the SVO2 or the SaO2, right? But either way, ignore those two things. The only thing that you want for the criteria is PaO2 and FiO2 to determine the hypoxemia levels, right? So it doesn't matter. All you're going to do is just look at the FiO2. And so obviously if it's 60%, plug that into the calculator, you get 0.60. And again, if you're not aware how to do that, just take the percentage, right? And make it into a decimal. And basically, it's pretty much going to be the percentage because it's out of 100, right? So 0.60 equals 60%, 70% equals 0.70, so on and so forth. So all you do is then you just divide it, right? So then you divide the 80 by the 60%, obviously 0.60, and then you look at the level. What's 133? Okay, so if you go into here, 101 to 200, that's moderate, right? And so the rest of them follow it. So I'll give you guys this thing, but all you have to do is just get into the mindset of what do you do when you see it, right? So it's not necessarily hard per se. It's just kind of how do you slow yourself down and how do you just remember not get so overwhelmed with the amount of information that she gives you? Because she can give you a whole page amount worth of information, but the only thing you have to look for the definition of ARDS and to determine the hypoxemia is those two values. So you could technically ignore every single thing else and just go based off of that. So how she's going to ask this in the other way is in a question, she'll put all of that information, the ABGs, the vital signs, the mode settings, all of that stuff. And we'll go over the mode settings and kind of how, if she doesn't give you like the respiration rate or the PEEP, how can you determine that it's PEEP? How can you determine it's FiO2? So she might give you all of this information, and then she's gonna have like 10 select all the applies, and she might say like, okay, you're gonna increase the respiratory rate. So that goes back to what you guys talked about last week, and we'll talk about it again in a second here later on. But all you're gonna do is you do each step at a time, right? So if they give you all the modes, if she gives you all the vital signs, if the temperature is high and it says give an antipyretic, you're gonna do that, right? If the patient being ventilated and she wants you to determine whether or not you're increasing the respiration rate, decreasing the tidal volume, whatever it is, all you have to do is follow the exact same steps. And then in addition, if she's asking you about ARDS on top of that, so it's like you're thinking about every single thing that she's talking about so far, right? So you're going, if she asks you about like what, she gives you the ABG, she asks you in addition, like in a select all the apply, is this metabolic acidosis or alkalosis, right? And if it's correct, then you select it. If it's not, it's not, right? So that's all you're doing. Go to each select all the apply, go one by one, and just go, okay, so she wants me to think about the vent settings right now too. So we have to change the respiration rate because the CO2 is super high, right? Like in this one right here, even though I had this as an example for the ratio to do the math, right here, if you look at the CO2, the 50 is pretty high, so 35 to 45. So with that, you already know that you have to change the respiration rate and the tidal volume. So she'll give you that in the selectively apply. So you select those. And then additionally, if she gives you, like in the story, she'll tell you like, okay, they came in here within 5 days, and then select all the apply, it'll be like, okay, they came in here within 5 days. That meets the criteria for that. And she won't say specifically, like, here's the question. It's a whole case study, and then select all the applies, and you just have to select if they're true or if they're not. That's basically all you're doing. So if it's true, it's true. If it's not, then don't select it. So go down the list, and even though she's combining 50 of these things, the difference is that I feel like that is a lot what NCLEX does, and I feel like that's a lot about, like, in the real world, like, you're just gonna look at it and be like, yep, that's true, that's false. No, yeah. So that's the good thing with it, but don't overcomplicate yourself. Don't Another thing is don't overselect. If you feel like there has to be more, the thing about her, she doesn't mind doing one, she doesn't mind doing all of them. So if you know that this is true, then do it. If you're not sure, then don't select it. But either way, kind of get used to saying it's her combining 50 different things. Because I remember the first exam, I was like, oh, she wants us to do event settings on here, ARDS. She wants us to talk about the ABG. And they were all within, like, the question. And I kind of was like, and they're like a whole page long, right? But at the same time, it's pretty simple when you think about it. Just go step by step. You see that there are event settings on there. Well, let's see. Do they actually need changes in event settings? If the PaO2 is at 80, so that's fine. We don't have to change anything. The PaCO2 is at 50, so we do have to change something because it's abnormal, right? But if it was at like 42, I wouldn't have to do anything, right? And then, so combining these things, and then even with these questions right here, you technically could also do the PaO2 and the FiO2 ratio with these, right? So keep that in mind. So they're kind of always going to involve each other in some way. So don't be surprised if you see both of those things for sure. So that's all you have to know really in terms of ARDS for that portion. So just know that definition and that criteria. So within 7 days, less than that, you're going to select it. The PaO2 FiO2 ratio, if it's hypoxemic. So if they're above 300, we're fine. You're good. If it's anything within mild, moderate, severe, they have it, right? So select it. And then just make sure, obviously, it's the same level to what it corresponds to. So if it's 201 to 300 mild and so on. And then checks X-ray, CT, bilateral. You have that, great. And then it's not a cardiac issue. It's not something else. It's fully respiratory, great. That's another one. Okay, so I'm gonna just go over this for like a quick second because again, you guys haven't gone over this, but I feel like she does end up asking a question, and I'll probably put this on your exam review about like the direct/indirect risks, but she doesn't say like direct or indirect. I think she just asks for causes or risks. So for direct, that's anything pulmonary, and then indirect, that's not, right? So sepsis causes ARDS. So she gives you like a septic patient and is like, what are some complications? Well, yeah, you should be worried about ARDS, right? So usually anything that's just outside of the range of pulmonary is indirect. Direct, straight up talking about pulmonary, respiratory issues, but I feel like all of them relate to some type of like aspiration. Because it's like, okay, drowning, toxic gases, aspiration literally with gastric content. Pneumonia leads to aspiration. You literally have things in your lung. Trauma, it could also lead to aspiration. So literally, I feel like it's just surrounding those things. But that's the other thing that she asked for ARDS. Later on the semester, you will also notice throughout her exams, she will ask you things that you did not talk about, like, for a while. So for an example, we're talking about ARDS now, so you expect on her next exam, she's going to talk to you about the Berlin criteria, which she absolutely will. But in future exams, like on exam 4, when you were talking about like other things, right, like DKA or whatever, she might ask you some ARDS signs, even though like that was on a previous exam. So you do need to start keeping these things in the back of your brain and just kind of get into the, I guess, way of thinking where it's like every single thing that you learn that she points out and that I'm pointing out, you do have to know for every single exam. Because in one exam in particular, I think it was the 4th one, we all were not expecting to see some of these things. Because I feel like with nursing school, you learn information, it goes out of your brain and out of your head, and you move on to the next subject. For Mandiola's class, you can't be doing stuff like that because she will probably bring up these questions, and I wouldn't be surprised. She will keep asking you about vent settings for the entire semester. She will keep asking you about dysrhythmias and stuff for the entire semester. We haven't gone through it, but she will keep asking you those things. She will ask you about this criteria throughout the whole semester. I don't know if she gave you guys the actual penicillin question. I haven't had anybody who told me, but basically, like, she asked us that every single exam, except for like the last one, or the last, no, I think with like one in the middle. And that's basically how it works with her class. So once you learn about it, you kind of, especially if I'm emphasizing on it and she is, like with the criteria, you need to know that. Especially the PaO2 FiO2 ratio. She will continue to keep asking that. But the good thing about that is once you get up to the final, I feel like even though I'll talk to you guys about the final and how that went, but I feel like because I knew that she was going to keep asking those same things, I never let this stuff leave my brain and I would keep reviewing it at least each week if I forgot. And it helped me on the final because then really I feel like I was just reviewing for the final. So make it easier for yourself now. Learn it while you have time since you guys don't have an exam. So get it down, write it down 50 times if you have to. But really, this stuff is a little bit simpler. I feel like for the at least the math for the ratio and the hypoxemia level. So just know that. So she does ask a question about that. For the stages of ARDS, it's so funny because I feel like she asked this question on like exam 3 or 4 when we went through it, and I was like, oh, I don't remember. And so she does ask about the stages for a second, but I think the only thing she asked was like if it was within a short amount of time or something. Um, but we'll go through that next week when you guys actually go through that and everything. And then we're gonna talk about kind of the vent settings right now and then the modes because you guys haven't gone through the rest of ARDS, and I'll go through the rest of the information with you guys next week. When you guys learn about it, or I might record something early so you guys can kind of get an idea of what to expect for the next lecture. But really, the number one thing I feel like that we'll talk about is kind of how do we incorporate ARDS within a vent setting. So we'll talk about vent settings in a second, but just know that even if regardless of like their modes and everything, so right here we're talking about increasing the respiratory rate, increasing the tidal volume, all those things depending on what values they have. If it's an ARDS patient, most of the time you should not be selecting to increase the tidal volume. Even if their CO2 is high, do not really select to increase the tidal volume because we'll talk about it in a second, I'll bring it up, but the only reason why is because we're wanting the tidal volume to be lower because of the barotrauma risk if you associate things with volume, right? So we'll talk about that in a second, but I know I talked about it last week, the difference between pressure and volume, but just know for ARDS, don't select to increase the tidal volume with it because you shouldn't be doing that with ARDS. Even if they need it, you have the other value of doing the respiration rate. So don't be doing tidal volume because I feel like a lot of people got that wrong. But again, it kind of depends on the question and kind of what you're looking at. But again, if they're usually ARDS, we kind of want to keep more of the PEEP, less of the tidal volume, even if their CO2 is high. So we'll talk about that. But really, that's all with ARDS. I feel like she's really going to harp on. We'll talk about the stages next week because that could be a question she asked. It was only one, but she will definitely on every single exam ask for the criteria. So I at least wanted to preface and emphasize on that. So now getting into the modes and the vents, because again, I feel like this was kind of, I feel like the lecture class is like 2 hours, but really she can make it into like 30 minutes or like an hour if she wanted to. But okay, so you talked about type 1 versus type 2. Type 2 CO2 has 2 in it, so that's how it's easy to remember. You know, causes intrapulmonary, extrapulmonary. It's the same exact thing as kind of like indirect versus direct causes. Direct causes are pulmonary related, indirect not, right? Like with ARDS. So pretty easy to remember that. And I know that she probably asked some type 2 stuff, like what causes not causes, but like what are some causes of type 1, what's related to type 2. So I wouldn't be surprised if she keeps asking that. But really, the one thing she will ask about is the modes, the settings, and how do we change that. So I talked about this last week, but I don't mind going over it again, a little bit more in depth. So negative pressure. When we're talking about negative pressure, that includes those 2 examples. But really, why it's called negative pressure is just because it's changing the pressure of the thoracic cavity. So it's not directly putting air into the lungs like with positive pressure. Positive pressure ventilation, when you're actually putting a vent, if they're trached or if they're intubated with an endotracheal tube, right? So that's through the trachea there, tracheostomy, just directly to the trach. So the reason why it's positive pressure is because it's directly blowing air into their lungs. Whereas with negative pressure, the iron lung and the other one are basically changing the pressure. Because again, we've talked about positive to negative pressure in terms of air inhaling and exhaling, right? So basically, it's the same exact thing of what the iron lung is doing, but it's working on the pressure of your cavity, of your thoracic cavity. So it's allowing the chest to expand. So it's not pushing air into it like a positive pressure vent. It's not doing that. It allows air to go into the lungs by changing the pressure of your thoracic cavity. So by working on the chest, it changes that. So it allows the chest to expand, right? And if it's expanding, that means we have more volume. More volume in a space, you have less pressure, right? Just like our arteries. And you have to think about it like vasodilation, vasoconstriction, but it's the opposite because we're talking about obviously we're talking about respiratory, so it's different. But technically the same, bigger volume, less pressure. So because of that, it allows airs to flow into the lungs. So it's kind of like saying it's negative pressure, but it's because it's not directly blowing air into the lungs. It's negative pressure because it's creating that negative pressure by expanding the lungs and create working on that chest cavity. So it doesn't directly put air into it. It creates that difference through the chest expansion and creating less pressure through that. And that's what allows air to go into that. Whereas with positive pressure, and it's going to sound like I'm repeating myself 50 times because I just want to get it into your heads, that's directly putting air into the lungs. So negative pressure is not. That's just, and again, if you watch the videos of like the iron lung, and that one guy, you can see it go in and out. So that's working on the chest cavity, which allows air to go in. Whereas with this one, we're directly putting air into the patient, right? So we don't need something to act on the chest. That's not what it's doing. It's not changing the pressure of the atmosphere in the chest. It's directly just putting straight up air into your airway. So in terms of ventilators, I hope that makes sense in terms of negative versus positive pressure. So in terms of ventilators, so obviously putting air, helping with direct breathing, helping with that. So there's two types of ways that we deliver breaths through vents, right? Pressure and volume. So I talked about it last week. I'm probably going to say the exact same thing because that's just how I think about it. And I don't think you have to overcomplicate this and think about it in the way that you have to. But really, with pressure, that's how much push we're putting air into the lungs. That's not how much volume, right? Think about it like with volume, we're always talking about mLs. Like I think about chemistry, I think about biology when we did the labs. You're pouring something into a graduated cylinder or whatever, a beaker, and you're weighing it, and it counts as this many mLs. You're weighing your food, it costs this many, or it equals to this many grams, right? You're thinking about the actual volume, the actual mass of something. Whereas with like a pressure, that's just like how much push, how much force we're doing something, right? So basically the advantage to that is that obviously your pressure is limited and there's no barotrauma risk. So the way that I think about barotrauma, it's literally called like lung injury, but I talked about it last week in the video. Basically, how I think about it is like if your lung is gonna pop. So if your lung is like a balloon and you have barotrauma, like if you're putting more volume, if you're blowing into that balloon and you keep blowing into it, that balloon will eventually pop. So that's kind of how I think about barotrauma and volume, right? If I keep blowing into that balloon, it's gonna pop. But the thing about pressure, I'm just changing the pressure of how I'm getting air into that. And so I guess the question is like, okay, so I can understand how people think, well, you're more interested in volume rather than pressure because pressure is just like pushing it, whereas air is like when you're putting the volume, it's like how much air is actually going to it. But again, not every single patient has the ability to get that much air or oxygen in one like breath. So with like babies, they can't get like if I'm putting a BVM on them, right? Let's say um if I used an adult one, I'm gonna pop their lungs. And that's literally barotrauma because I'm putting a whole bag of volume of air into their lungs. An adult can handle that, but a baby can't because they have different sizes of lungs and they have fragile lungs. It's the same exact thing with ARDS, right? Their lung size isn't different, but what's happening is that their lungs are fragile, just like neonates, right? So it doesn't make sense to put as much oxygen and keep giving them oxygen even though they need it. And I understand that concept of like, well, they need more oxygen. Okay, but we can't do that. What we can do is change the rate of which how much we are giving them oxygen. And that kind of lies into what pressure is, but it's just the push, the force of how we can push that oxygen into them. So I hope that makes sense because I feel like all I think about is pressure, is the push, volume is the actual amount of air that we are giving. So, with that being said, for the disadvantages for volume, and all you have to think about is, yeah, like if I'm blowing up a balloon, I'm putting more air into it, I'm putting more volume into the balloon, I'm gonna blow up the balloon, I'm gonna blow up the lung. So it's the same exact thing with that. So for an ARDS patient, that's why I was saying for an ARDS patient, it wouldn't really make sense to, even though their CO2, and we'll talk about it, may be high, right? In the vent settings, you should be changing the respiration rate and the tidal volume. You can change the respiratory rate, because again, that's a little bit different. But if you're doing the actual tidal volume, so tidal volume and volume are basically the same thing, but they are the same thing. But basically, you can't be doing that because the problem is that they have fragile lungs, and you should, yeah, just kind of change the respiratory rate because that's the other option that they give you. So that's why we have multiple different modes and settings because some patients they can get more of a tidal volume, but some patients like ARDS patients they can't. So we'll just work on the respiratory rate to get rid of the CO2 and those type of issues. But really, with like an ARDS patient, it's not necessarily more of a CO2 problem. It's just that they're hypoxemic, right? It has nothing to necessarily do with CO2, right? But it's we're looking at impaired gas exchange, so you can have those problems. But if we're talking about the criteria, it doesn't say CO2 on there; it says PaO2, right? So most of the time, you're going to be changing the PEEP and the other thing, and right, that's just based off of the chart. But that's why with ARDS, really, you should not really be changing the tidal volume at all. Just because the lungs are fragile and you don't want to pop the lung and create barotrauma. Barotrauma, lung injury, just think about popping a balloon, popping the lung. So I hope that makes sense. That's kind of how I think about it. So pressure versus volume, pressure, push, volume, amount of air. Don't want to pop the lung. Okay, so types of positive pressure ventilation. So you have invasive ones and non-invasive, right? Invasive, only two of them, the ET tube and then the trach tube, right? So those ones go straight up into their airway, whereas with the non-invasive, like we can still put a mask on them, and it's not necessarily directly going into their airway, but they're getting that oxygenation through that. So one thing to note is that she won't ask you this, but sometimes in clinic, I feel like they ask you this. If a patient's having respiratory distress, and you know that the oxygen like masks or whatever aren't working, you could put them on CPAP and BiPAP first if they're struggling. But if that doesn't work, then you prepare to like intubate, right? But basically, you can still do those things, and CPAP and BiPAP are very much well used. If the patient does have oxygenation problems, but it's like they can still breathe on their own, they're doing fine. But you need a little bit higher than the masks, than the non-rebreathers, and everything like that. But eventually, we do intubate because I feel like the reason why is because it just decreases the O2 demand, right? And I think that's the reason why we intubate most of the time. Because I guess the question is like, well, why don't we just keep them on CPAP and BiPAP the entire time? But if they can handle it, then sure. But again, that's determined by the physician, by the RT. That's not necessarily our job, but we can know like what the patient's respirations are like, what their work of breathing is like. So that's something to know as well. But really, like in a clinic setting, you could say, yeah, like if they're not breathing, you can put them on BiPAP and CPAP first, and then you move on to intubating. But again, let's take it one step at a time. We're not straight up going into intubation. If they need a nasal cannula, put them on a nasal cannula. Okay, so in terms of the settings, so I went over this last week, but I'll go over it again. Again, like I'm not gonna be reading all of this stuff because I just feel like don't overcomplicate it, don't overthink it. But we'll talk about it. So respiration rate. I think we all know what that is, right? Our regular respiration rate, how we're breathing in and out, the frequency of breaths that the ventilator is giving. And so the reason why this is important is because obviously if they're breathing too low, we can have the accumulation of CO2, right? Because if I'm holding everything in, not breathing as much, none of that CO2 is being exhaled through my breath, right? So it also just helps to kind of see the patient's work of breathing, if they're comfortable. If I'm breathing too fast and like my chest is going up and down, I'm gonna get tired, right? So no, let's keep it at a set rate. So let's do that. So frequency of breaths, right? Tidal volume, same exact thing as the volume. How much amount of air are we giving for each breath? So I look at the respiration rate, it's 12. And then I look at the tidal volume. Remember, it's going to be in mLs. It's going to be like the volume of something, the mass of something. So it's going to be mLs. And then usually it's a pretty high number. So like 400, all of these different things. So really it's based off of their weight. It's based off of what the physician wants, what the RT wants, and how much they can handle, right? But again, with somebody like neonates or ARDS, if they have very fragile lungs and they can't take as much amount of air, you're going to pop that lung. Would it make sense for me to put the same amount of tidal volume for a baby than it would for somebody who's an adult? So, amount of air. So, don't overthink that, just the volume, mLs, that's how we see that. So, based off of the respiration rate, if I have 12 as my respiration rate on a vent, the tidal volume is like 400 mLs. That means I'm getting 400 mLs of oxygen for every single breath, which is in those 12 breaths in a minute or whatever. So there's that. FiO2 is the percentage. So notice how it says percentage, right? So she gives you, we'll go over the values and how to read it. But sometimes she doesn't give you like, this is the FiO2. Like you just have to straight up read it. And in clinic, that's how you should be saying it. You just read it straight off after one another. So it's okay if you say like FiO2, but just know like eventually if you're actually working on a floor, usually they don't say that. Usually they're just like, okay, ACVC 12, 400, 20% or whatever. So basically percentage of oxygen a ventilator delivers to a patient to increase oxygen levels in the blood. So this is, I just think about it, the concentration of oxygen. So basically with the nasal cannula, remember it had like the 22% or 24 to like 44% or whatever, and every single mask had a certain amount of percentage. So for every single, the tidal volume is different, that's the amount of air. And then FiO2 is involved within the tidal volume because it's saying this is the concentration of oxygen. So in terms of our SpO2 levels, how can we improve that with the concentration of oxygen? So that's what it kind of means. So it's just talking about concentration, kind of, I would think about it like, okay, if your tidal volume, like you're drinking a Gatorade, your tidal volume would be like the amount of Gatorade you're drinking. But the FiO2 would equivalent to the amount of like electrolytes in your Gatorade to make you like replenished, right? If your FiO2 was like 0% and you're giving like a tidal volume of 400, well, that's not going to do anything because, yes, you're giving 400 mLs of tidal volume of oxygen, but there's no actual concentration to that oxygen. That kind of goes into chemistry because it's talking about like O2 and all those chemical compounds. Do I know that? Absolutely not. Do you have to know that? No, because that's not in your scope. And technically, some of this stuff is more of like an RT, but that's how I would think about it. Like if I'm drinking a Gatorade, the amount of I guess the respiration rate would be like the amount of times I'm picking up the Gatorade to drink it. The FiO2 would be like the concentration of the electrolytes in it to replenish me, right? And to keep me hydrated. And then the amount that I'm drinking. So it's just saying the concentration in the amount that you're giving. So I hope that makes sense for that. So it is kind of all tied together, but I would just think about it. So far, respiration rate, you already know that, how many breaths we're giving. Okay, so then the next one is tidal volume, so how much amount of air. And then the FiO2, what's the concentration of that air, right? Okay, and then the last thing is PEEP. So the thing with PEEP, and we'll talk about it in a second too, with like CPAP, the thing with PEEP, it's that it's positive end expiratory pressure into the airways during expiration. So basically what it does, it keeps the alveoli open the entire time. So if it keeps them open even during expiration, the good thing with that is that there's basically, it allows more air to remain in the lungs, right? So there's better gas exchange, there's more oxygenation as a whole. I feel like that just makes sense because it's like you're keeping it open the entire time. So if you're keeping it open, you just have more ways of getting oxygen to that alveoli and you're having it have more time for gas exchange. And there's that. But the problem with that is that it also creates barotraumas. But think about it again, like the volume, if you're giving it a certain amount of air, basically you can pop the lung, create a lung injury. With PEEP, you're keeping your alveoli and your airway open for the entire time. But eventually that can create a lung injury because you're keeping it open the entire time. You're not letting time for it to relax or to rest. And if you keep wanting to get a bigger PEEP number, the problem with that is that you could also get the amount of air that goes into your lungs is a little bit more. So that's why you have like the barotrauma risk. But really, it's just because you're keeping it open the whole time, your airway is going to get tired. And your lungs are going to get tired as well because you're keeping it open the whole time. And there's that. But really, the good thing with this is that it keeps it open, better oxygenation. That's all you have to know. So PEEP, keep alveoli open all the time. Okay, inverse ratio. So this is basically talking about your duration of inhaling versus your duration of exhaling. So usually, like for us, normally when we're inhaling, it's shorter than when we're exhaling. And I feel like that makes sense because like you have to think about like if you're sighing, like sometimes you're breathing in a lot or you kind of just want to break and then you sigh, right? So you go, so usually that's how I just think about it. Like your expiration is usually longer. So usually the ratio is set 1 to 2, right? Because inspiration is shorter, expiration is longer, so it's 1 to 2. Okay, so on a vent, you can change this because again, like we talked about with PEEP, if you're keeping the airways open for longer, you're having more ability to have be better oxygenated. So if I'm doing an IE ratio and I'm usually exhaling longer than I am inhaling, I can change the duration of which I'm inhaling to make it longer to improve oxygenation. And it's sort of I feel like in theory it's kind of similar to PEEP because again, like you're trying to keep the airway open a little bit longer for inhaling, but really all it's doing is just it honestly is kind of the same because it's if you think about it, this is giving the alveoli more time to reopen. So the difference is that you're not keeping it open the entire time. With PEEP. You are. So inverse IE ratio, that means that we could be changing it like 2 to 1, 2 to 3 to 1, all of those like 2 to 4 to 2, like you can be changing it, right? So basically keeping the inhalation longer helps you to kind of grab more air and allow more air to go into the lungs. So if I'm inhaling for longer, more of the O2 just came into me, right? And if I'm exhaling, I'm just getting rid of the leftover CO2, but I'm not getting rid of some of that oxygen. So that's why we just want better O2, better oxygenation with that. I hope that makes sense. So far, you have the respiratory rate, frequency of breaths, you have the tidal volume, the amount of air I'm giving, that's going to be in mLs. You have the FiO2, which is the concentration of oxygen I'm giving. And then now you have the PEEP, that's keeping your airway open the whole time. Those are just extra stuff, is basically what I think about with PEEP and IE ratio. This is like the extra stuff. For those other things, you absolutely need them. For PEEP, that's just how can we improve oxygenation. With IE ratio, how can we improve oxygenation? The other things, if you're putting somebody on a vent, you absolutely should choose those three things: respiration rate, tidal volume, and concentration of oxygen any day. Because again, PEEP is just how can we improve their oxygenation status, and then IE ratio, how can we improve it even more? And I don't really see a lot of IE ratio in clinic. We'll talk about one of the vent modes, so there's that as well. But I just feel like this is just extra stuff of how we can help out with that. Okay, so for alarms, I recommended this to a student. So since you guys have a little bit of time, I would recommend this as well. For your NCLEX, I'll probably give you guys some advice for that. It is kind of just like a guessing game the whole time, which kind of sucks. But I used, I'm pretty sure everybody's heard of him, Mark K. But he talks about vents in like 5 minutes, and I timed it up by 2, so it was even like faster. But he talks about vents in one of his lectures, and I can send you guys the notes for that really short too. But he just discusses the vent alarms because really all you have to know if there's a high pressure alarm, what he's talking about is like that's an obstruction, right? So if you look at all of them, it's like so there's anxiety and inadequate sedation, so that is one. But like if you look at the H2O secretions, kinks, coughing, talking, like gagging, you're all going against the vent. So there's a lot of resistance. There's a lot of obstructions. So that's what he says. He says like high pressure is obstructions. And so how do you get rid of that? Well, secretions in the tubing take up the secretions. You're going to suction. If there's kinks in the tubing, you're going to unkink it, right? So if they're coughing or gagging, you just suction them, right? So it's just very simple. So high pressure, I would just think about obstruction, but I would recommend to at least listen to him for like a good second, and he explains it pretty well. Um, but all he does is he just sums it up exactly like kind of what I'm doing. High pressure obstruction, whereas with the low pressure, that's a disconnection, and that's what he says. And I feel like that would have been helpful to listen to him in school. So low pressure, basically, disconnection, high pressure is an obstruction. So with low pressure, if it's a disconnection, there's leaks, right? So there's a disconnection somewhere in the tubing. And then basically, if it's disconnected from the machine, don't worry, just reconnect them back, right? So nothing too bad there. Apnea alarm. Well, we all know what apneic, like an apneic patient, that means they're not breathing. So there's something going on with the vent if they're no longer breathing. But I feel like that one's pretty obvious because it's apneic. And then low volume, again, it's going to be the same thing. There's a disconnection somewhere because they're low, right? So really all you have to know is high pressure, obstruction, low pressure, disconnection. So she doesn't even ask you anything about that. She didn't ask us anything about that. So I kind of was like waiting for stuff, but I didn't even look at this really, and I kind of felt lucky because I was like, oh, she didn't even ask us anything about it. But she didn't ask us anything about this stuff at all. throughout the entire semester. But again, I wouldn't doubt, there's things that can always change, but really all I feel like you have to know is high pressure, obstruction, low pressure, volume is more of a disconnection. Put them back on it. With an obstruction, you can take out the secretion, suction them, you can unkink it, that type of issue. Okay, so then the last thing that we're going to go through again, because I was like, this is going to be a very short lecture, is just the modes and the settings. And then we'll go over the chart again. But again, I went over that last week. But the rest of this stuff, you don't have to know this. I don't think so. You can just read it really quickly, how it is right here. And she didn't ask us anything about this. So I feel like she didn't even ask us about ventilator-associated pneumonia, which I kind of was like expecting her to, but she didn't. And then again, she didn't ask us about modes. She asked us more of like how to change the settings. So just that chart. She asked us about like when do you know the indicators to intubate somebody. So those values down there. But she did not ask us about modes, so don't overthink it. So to explain this, because again, it is super confusing and I understand it. You've never seen anything like this before. So modes, how breaths are delivered to the patient. So in what way are we delivering? So again, we have those two types of ways ventilators can deliver. Those are pressure, and then those are volumes. So pressure, the push, the amount of air, how we're pushing, and then the volume is the actual amount of air we are delivering to the patient. So with a volume controlled mode, we have a set tidal volume. So again, volume, right? So how much volume we're giving whenever they inhale, and then pressure controlled. What is the set pressure that we have set, right? And so how do we make sure that it doesn't vary throughout them inhaling? With triggering, the thing with that, this basically means, so that's where I feel like people get confused is just with like the triggering and the breaths that the patient delivers. So triggering and spontaneous, basically triggering is just like if the vent triggers the patient to breathe. So if it says trigger, it says like the vent is making the patient breathe for them. For spontaneous breaths, that means that the breath is actually like it's coming from the patient. The patient is literally breathing on their own. Whereas with triggering, that's more of talking about the vent is triggering the patient to breathe. But that's not caused really by the patient. That's more caused by the vent. So if I were to take them off the vent, they would not be breathing on their own. It does not mean that they're ready. That basically is just saying the vent is triggering them to breathe. It's kind of like how some maneuvers, like vagal maneuvers, like change things, like or like they just trigger our body to do something. Like if I were to bear down, that can decrease my heart rate. That's just triggering your body to do something. So the vagal maneuver is causing that. So with triggering, again, the vent is causing them to take a breath on their own. Whereas like with the spontaneous breaths, that means that the patient is taking a breath on their own. And then mandatory, the ventilator is giving them a breath, right? So that's basically what the vent is doing anyway. So mandatory breaths. But all you have to know is triggering. That's kind of more related to the vent, kind of doing that stuff, triggering the patient to take a breath. Whereas with spontaneous, the patient's just spontaneously breathing all of a sudden. So, basically, with these two modes, all you have to know is that there's CPAP and BiPAP, non-invasive positive pressure. We talked about that already, though. You don't even need to know this. It's just kind of like, yep, they're non-invasive. They're not intubated. It's just basically a mask. But let's just go into the differences between CPAP and BiPAP. So obviously, BiPAP, two different levels of pressure. One when they're inhaling, another one when they're exhaling, right? So that makes sense because it's called BiPAP, so two. Continuous. So continuous the entire time, it's going to be the same amount of pressure. So to describe CPAP, it is basically identical to PEEP. So remember, PEEP is like you're keeping the alveoli open the entire time. So CPAP is basically the exact same thing. Is you're keeping the airway open. You have a certain amount of pressure open the entire time. So that's what CPAP is. It's like, okay, the same exact, if not identical to PEEP. So that's what's great about it because it increases oxygenation, right, with CPAP. So that's why it's great. But here's the thing. I feel like this is just common sense, so I think you all know this. A patient who cannot breathe at all should not be on CPAP, right? They need to be able to breathe on their own, but they just need better oxygenation, right? When you think about obstructive sleep apnea, we have the BiPAP, the CPAP, or those things, right? But that's just because the reason why we give them those, they're not having issues with breathing. They can still breathe, and they're not going to die. The problem is that we want them to sleep better because the reason why they're not sleeping the best and why they're snoring all the time is because they're trying to get more air and their airway's getting closed. So if I give them a BiPAP or a CPAP that keeps their airway open for longer and the entire time, you have better oxygenation. But they can still very much breathe on their own, right? So do not be giving this to a patient who definitely not breathing, and they need to be intubated. They need to have one of the other vent settings on. Okay, so CPAP, basically the same exact thing as PEEP, pressure, literally the name. So speaking of names, we'll get into that in a second. But yeah, so basically, they're breathing on their own, spontaneous breathing. You see that right there. So this is a weaning mode, right? Again, they're breathing on their own. Spontaneous meaning that they're able to take their own breaths spontaneously. So basically the same thing as PEEP, continuous, all that stuff. So when I mention the names right now, the way that I want you guys to think about modes is to say their name out loud. Do not overcomplicate vents, because I know I was talking to a student. They went over. Mandiola goes over this chart in class, and she will continue to do that. Not in class, but in BAD, where she puts a chart and she says, "This one has a set respiration rate. This one has set this." And I understand how that can be confusing, but the way that I'm going to talk about it right now hopefully makes it less. Because all you need to remember for vent settings, and I was telling my RT friends about this because, with her experience as an RT, she even was like, I'm getting kind of confused with how it's being explained. And she learned about this stuff and she knows it. But the way that she explained it to me is she's like, you're overcomplicating this. Don't like try to memorize these things. Think about the actual name, right? So if I'm saying continuous positive airway pressure, think about the exact words that I just said: continuous, positive, airway pressure. Well, I know that positive airway, so like positive vents, they're getting direct air to them. And if it's continuous, that means it's the entire time, right? If I'm saying BiPAP, bi, right? So that's two different types of positive airway pressures that we're giving. So that's why don't overcomplicate it. And as we get into the rest of these, you're going to see that it actually makes a little bit of sense if you just think about the actual name of what. So I want you guys to practice tomorrow or tonight. Look at the name of the event and just don't overcomplicate it. Just take a piece of paper out and be like, okay, Genesis said, think about the name. So if I'm saying pressure control, I'm talking about pressure. I'm not talking about tidal volume. Okay, so let me go through that so you can see kind of how that works out. Okay, so I'm gonna skip APRV for right now, and I'm gonna go to pressure control first because you need to know the PCIRV before you know APRV. So I should have changed that up on the side again, but that's fine. So pressure control. Okay, Genesis said to talk about the name of the mode. Okay, pressure control. So notice how it says control, and I know that there's a support one, but we'll talk about that in a second. Pressure control. Pressure control is a pressure mode of ventilation with a set respiration rate. So for majority of these vents, you're going to have a set respiration rate. The only ones that you're basically not are the ones that are weaning. But you'll notice almost all of them actually do have a respiration rate. Okay, so if you're like worried that she's gonna ask you, she will. I don't think she will. I really wouldn't overcomplicate these. She's not gonna. I don't think she'll ask you a set respiration rate because trust me, in B80 when she went over that chart, I was lost and I was like, I don't know any of this stuff. But majority of them, they're gonna have a respiration rate. So you're gonna take your best bet. Probably go with the respiration rate, right? If they're weaning, they definitely don't necessarily need a respiration rate. So those ones can iffy. So if you have to memorize the ones that don't have a respiration rate, then you can do that. But honestly, majority of them will. I don't think she'll ask you that, but just think about it. Okay, Genesis says majority of them will. Okay, so basically, every single breath has a set amount of pressure. Okay, well, what did I just say that this mode was? It's pressure control. So they don't have a set tidal volume, obviously, as you can see right there. Well, where in the name does it say volume, right? So they're just saying, I am controlling the amount of pressure. That's literally it. For every single respiration, I'm controlling the amount of pressure. So basically, if I were to be on an exam and I were to see this, again, I don't think she'll ask you, but again, it's helpful to know. If I'm seeing a patient in clinic is on pressure control, PC, I'm going to look at it and be like, okay, no set tidal volume, but they have a respiration rate because Jessica said most of them do, and it's a vent setting. And then pressure, I don't see volume in there, so they have a set pressure and there's no set tidal volume because there's no volume in the term. Does that make sense? And then the other addition to that, if the patient triggers more additional breaths. So again, it says triggers, right? So they're triggered. They're not spontaneously breathing on their own. right? It doesn't say spontaneously breathe. It says that they're triggering. Because again, if I'm controlling the amount of pressure and if I have them on a vent, and this is not a weaning mode, right? That means like with CPAP, they're not spontaneously breathing with this one. It's just saying if the vent triggers them to breathe more, they will get the same amount of pressure. That's it. So it's like when she's saying, can they spontaneously breathe? I mean, technically, they could, any patient could with any vent, but it's just saying that really this vent could trigger the patient more. But I don't even think you have to know that. I just think it's more of just understanding, well, if they were to breathe more, and if the vent were to trigger them to breathe more, they would just get more pressure. That's it. They would get the same amount of pressure for every single thing, not more. Sorry, excuse me. It's just basically if they get triggered by the event to do more. Because again, keep in mind, like if they're on a vent and it's on a weaning mode, it wouldn't really make sense for them to kind of be spontaneously breathing. They can technically, but it's just saying every single breath, regardless, they are going to be getting the same amount of pressure. Okay, so moving on, pressure control inverse ratio ventilation. Well, we talked about inverse ratio earlier, right? Remember we said normally our inhalation is going to be shorter than our expiration. So our normal ratio is 1 to 2. Well, again, we said if we keep the inhalation longer, kind of like with PEEP, but again, PEEP is keeping it open for basically the entire time. Whereas with pressure control, inverse ratio, like the inverse ratio is just how can we make the inhalation longer so they have better oxygenation? So again, they're still going to have the same respiratory rate. It's the same exact thing as pressure control. The only thing is what you're adding to it is just a longer inspiratory pressure. So you're changing the RT knows how to do this, but they're changing the ratio to make it 2 to 1 or 3 to 2 or whatever they want to do. But basically, all you're doing is you're just adding that one factor on that for better oxygenation, right? So the one thing about pressure control, remember we talked about the difference between pressure and volume? Well, the good thing about pressure, that's talking about the push. That's not talking about the amount of air. Barotrauma was like lung injury, you're blowing up the balloon, you pop the balloon because of the amount of volume. So if I'm just talking about pressure, there's no risk of barotrauma, or there is a lower risk of barotrauma. So that's kind of how I think about pressure control, at least for that. So again, there's no set tidal volume because it doesn't have the word volume in it. It's just pressure. So for every single breath, they're going to have this pressure, right? So I hope that makes sense of how I think about it. And that's all I think you have to know and be able to explain. Because if you know that, you know more than what is expected. I don't think she'll ask you modes, but again, if you want to understand it, pressure control, think about the actual term. Okay, so now we're going to airway pressure release ventilation. So this one actually can be a little bit confusing, so I understand the confusion with this. So it's a mode that provides 2 levels of CPAP. So kind of almost the same thing. It allows spontaneous breathing because, okay, this is, I would think about vents like almost like they're on different levels. Pressure control, we're controlling the amount of pressure. They have a set respiration rate. We don't give a tidal volume because it's not in the term. But the thing is though, is that they can't really breathe on their own because they're literally on a vent. Whereas with airway pressure release, it says release in there. The patient still can kind of breathe on their own. This one's kind of a step down from pressure control and from pressure control inverse ratio because basically they can still kind of breathe on their own. They're still spontaneously breathing. And we have different settings and different things like this because the reality is not every single patient, like, why would we put them on the worst, or not the worst one, but the harshest, like, vent if they can sort of breathe on their own? Because then you're taking away the work that they're doing and you're going to cause them. It's kind of like how you give like COPD people, you can't give them high flow because eventually like you can over oxygenate them, but you're also taking away like the amount of like in the future, if you take them off of it, the work that they did to like cause them to be at a higher stat, you're kind of taking away their work for them and you're kind of just giving them oxygen like here's a freebie. But the problem is that that won't cause them to like work for it or kind of, I don't know how to explain it, but I guess um, get better on their own. Like you're just giving it to them. You're just giving them a freebie. Like here you go. So with APRV, it's basically a step underneath that. So of course they can still spontaneously breathe on their own, but it just gives them, it's kind of like almost similar to CPAP, but it's really similar to PCIRV. It keeps it open, you inverse the ratio, but the only difference is that the vent doesn't trigger them to breathe. So remember with pressure control, I just said that they can't really spontaneously breathe on their own because you're on an actual vent. It's pressure control. It says control in the actual term. They're controlling how you breathe, which means you probably aren't breathing on your own. And so because of that, pressure control inverse ratio vent, the same exact thing, you're just inversing the ratio. With APRV, it's saying that it's the same exact thing as PCIRV. The only difference is that the patient can breathe on their own. So the vent isn't triggering them to breathe, they're actually spontaneously breathing. So with that, I don't think you have to understand that, but I think the only thing you have to think about is, okay, if I were to rank them, I'm saying PC, PCIRV, and then I'm saying APIRV. So if a patient is coming in, they can still breathe, but they're having some like barotrauma risks, like with the ARDS, but they can still breathe on their own. They're not dying. I don't need to go to pressure control. I can probably put them on APRV first, and then if they get worse, I can try PCIRV. If that doesn't work, then I can try pressure control. But again, like those things just are based off of the patient's values. And she won't ask you, like, I don't think she'll give you values and be like, decide which event to put them on, because that's crazy and that's not in your scope. But basically, that's how I think about it, right? It says airway pressure release. So the patient is able to release their own breath. They're able to spontaneously breathe on their own. So I hope that makes sense. But basically, think about the name pressure control, pressure, PCIRV. I feel like that one makes sense. If you're still getting APIRV mixed up, I totally understand that. But basically, I was just thinking about it. It says release in the name. Release meaning that they can release their own breaths and they can probably spontaneously breathe. Whereas with PC and PCIRV, they kind of can't do that. It's more of like the vent can trigger them to breathe on their own and probably take an extra breath. But again, that's more of the vent doing the work, not the actual patient. And with APRV, the patient is actually doing some of the work. So it says it right here. So yes, in PCIRV, patients can sometimes have additional breaths if the ventilator is set to allow for a more spontaneous effort, but it really focuses on controlled breaths. So with PCIRV, the whole point is that they can't really breathe on their own. So it's on a pressure control. So because of that, they can't really be breathing on their own. Technically, they could be taking their own spontaneous breaths because again, that just means the patient is just taking breaths when they want to. Technically, they could, but because they're on this ventilation, they just can't breathe. So they're not going to be doing that. So it focuses more on how much pressure can we give. Whereas with the spontaneous breaths might not be easily integrated as an APRV, where patients can breathe freely at both pressure levels. So while additional breaths are possible in PCIRV, the mode is less flexible compared to APRV regarding spontaneous breathing. So APRV just gives them more, it's basically the patient can still somewhat breathe on their own. So I hope that makes sense. Okay, going into the next one. So again, think about the name. So pressure regulated volume control. So if you're thinking about this, it says pressure regulated volume control. So remember Genesis said most of them are going to have a respiratory rate. Does this one has a respiratory rate? Yep. Does it say volume in the name? Yep. Do they have a preset tidal volume? Yeah, because I just said pressure regulated volume control. Volume is in there, right? Okay. And then does it have a pressure limit? Yes, it does, because it also has pressure in the name. And think about the actual term, right? Like pressure regulated, it's regulating the pressure. Volume control, it's controlling the amount of volume. And this is the triple combo, right? Because again, most of the time, Genesis said they're going to have a set respiration rate. And then because it's in the name, you're going to have a preset tidal volume, a preset pressure. And then, yeah, the patient can trigger breaths as well. So that means the event is causing the patient to trigger some breaths. But again, you don't really have to know that. I feel like the only thing you have to know is that pressure regulated, has pressure, has volume in the name, and most of them are going to have respiratory rates. So this one is all three of them. Hope that makes sense. You don't even have to know the advantages or disadvantages because I feel like, again, it kind of gives those hints, right? All you have to know is like the benefits between pressure versus volume. Volume, more barotrauma risk, pressure, not as much. Okay, ACVC. So sometimes they call it AC, but basically what they just mean is assist control, yeah, and then volume control. So again, with pressure control, we're talking about controlling the amount of pressure within a breath. So again, remember Genesis said majority of the time we're going to have a respiration rate. Well, guess what? With this one, you do as well. Do you see pressure in the name for ACVC? I do not. I do not see a P anywhere. So because of that, they will not have any pressure support. But will they have a tidal volume? They will. They will have a tidal volume with that. So that's what makes sense for this one. Again, thinking about the name, and this one is the full vent support. So if any type, and I think the only reason why it's easy to remember this, when you start going to ICU clinic or people who are in ICU, you will see that they most of the time are on ACVC because these patients cannot breathe on their own, right? So I guess this can cause them to also trigger, and if they take, again, spontaneous breaths on their own, it takes that within that. and then there's a type of volume. So I guess it can get confusing because it's like, well, some of them they can, some of them they can't. But if you think about this, this is full vent. Like they're getting full volume. Like we don't even care about the barotrauma risk anymore with this patient. Because again, the pressure is just how much can we be giving them, like how much air, like the force of that. Whereas with this one, this is the amount of air that we're giving them, which literally means that they need the fullest vent support because this is the amount of air that we're giving them, the amount of oxygen of air, those mLs, they need that. Whereas again, with the pressure, how much force can we push into them? So with this one, it's like they can still trigger and they can still spontaneously breathe, but really, we don't care about that. We just want to give them this amount of air within this set breath. So that's with that. So again, think about the terms, right? Volume control, there's no pressure. So of course there's no pressure. And again, I don't think you really have to know the differences between spontaneous breathing and triggering. It's just that they all technically could breathe on their own. It's just that with the patient who's on pressure control or volume control, they probably aren't going to be because they're fully like needing the extra help. The only difference is like if we were to put, again, ranking, I would put ACVC above pressure control because the pressure with that is, again, like with volume control, we're worried about barotrauma, right? At this point, this patient just can't breathe on their own. They're not getting any air. So I'm just putting them on full vent. And that's just basically what it is. And then the difference between pressure control, again, that's just the push of air that we're giving them. So we're worried about ARDS and all that stuff. And even though that still is a pretty good like support, that means that the patient still is struggling to breathe. The difference is that with volume, if I were to choose putting them on PC or ACVC, if the patient can't breathe at all, like at all, I'm going to choose ACVC every single time because that is the amount of air we're physically getting. So again, if you have to think about it like ranking it, do that. But again, just think about it like the name. So, PIMV, okay, so synchronized intermittent. Your keyword in that one is intermittent, right? So again, I talked about knowing what the terms are and just thinking about the names. So they have a set respiration rate. Genesis said most of them do. They have a set tidal volume, right? And really, I feel like the thing with this one is all you have to think about is I would just think about it like, even though this one doesn't have the term volume in it, the difference is that it has synchronized intermittent. So it's just saying that this is a weaning mode because the event is synchronized to the patient's breaths intermittently. That's basically all it's saying. So patients can trigger, their own spontaneous breaths because they can breathe as they want in between the vent breaths. So basically, you have mandatory breaths that the vent's giving, right? And then the patient can breathe on their own if they want to. So all you have to know with SIMV, and I don't even think you have to understand like why it's set respiration, set tidal volume, all that stuff. You just have to know that it's a weaning mode because again, synchronized intermittent, that means that the vent is synchronizing to the patient who is intermittently breathing here and there. And it will literally match the patient's effort. And that makes sense because it says synchronized intermittently, right? So you get a set volume and you get a set respiration rate because Jess said most of the time you don't. This one doesn't have the word volume in it, but the difference is that it makes sense if you think about it. Like it wouldn't really make sense if they were synchronizing to the pressure. It's just synchronizing to the amount of air that it's wanting to give. So that's it. So if you feel like you have to memorize this one, then do it. But really all you have to know, it's just weaning. That's pretty much it. So this vent will match the patient's effort, making it synchronized. So again, just talking about the vent. So if you see a patient who's like on SIMV, and then she asks them a question like, well, they're not really breathing anymore. Do you want to keep them on SIMV? Probably not, because this is, again, a weaning mode. So if we're getting ready to take a patient off a vent, we can start them on SIMV or change the modes to SIMV so we can allow them to kind of relax, help them to preserve that muscle tone, and that's when the patient starts to breathe fully on their own. And I guess the question is like, well, couldn't we just put them on the other ones? Well, yeah, you can, right? Like you can, if they were on ACVC and then like now we're worried about the barotrauma risk and everything, but they can now sort of breathe. Well, now you can put them on PC or PCIRV if you want them to have better oxygenation based off of their PaO2 levels, right? Okay, after that, then it's like, okay, there's APRV. That means that they're maybe starting to spontaneously breathe on their own. Okay, and then now they can just breathe on their own. Okay, I think that they're going against the vent a lot. So they're having like, you're hearing the high pressure volume and you're like, okay, I think they're talking against it, which means like, it seems like they're kind of ready to get off of this one. So then you can put them on something like SIMV. And so do you see how like there's kind of a rank within each of them. It does You're not gonna see that within the hospital. Usually, it's just gonna be they're on one, and then usually they'll get off of it and kind of be on SAMV or whatever. But they'll slowly wean them off of that and then change the mode. But it's not gonna be like 50 different ones. But if you have to think about it like that, think about it like that within how like they rank, kind of. Okay, so the difference between pressure control and pressure support. So now we're talking about the term support. We're not talking about control. We're not like we're controlling somebody to do something. We're talking about just supporting somebody. So they don't need the control over it. They just need some extra help, right? So pressure support. It has the term pressure. So is it going to have pressure? Right. And so I guess in this one, it's like, well, why don't they have a respiration rate? This is like the one of the only ones that doesn't, right? So you can memorize that. But if you think about it, it doesn't have control in the name. It has support. So why would they need a set respiration rate if, again, this is more of like used with SIMV, right? Like it's kind of more of a weaning thing. It's just to help them, if they're needing some more stability, right? And to decrease their work of breathing to allow that push that's going into them. So it doesn't make sense if I were to have a set respiration rate and it would be support, because it's like they can kind of already breathe on their own. They just need the extra support. And all we're doing, it says pressure in there, so we're having a set pressure. There's no volume, but again, it's support. So we don't need that respiration rate, right? So it can be used with SIMV. It's again one or more of those weaning modes, and then it's just used with the client with stable respiratory status, right? So that makes sense. So do you see how like with a lot of these, all you have to actually think about is use the name? And yes, there are some things here and there where you're like, okay, I don't really understand that, but I feel like if you just understand like why it's pressure, why it's volume, and if you just listen to the name, that's all you have to do. So I would recommend to get a piece of paper out either today, tomorrow, and just think about the terms. And then all you have to do is just think, okay, you said most of them have respiration rates. If it's weaning, sometimes you're not going to have one. Like with pressure support, it's more of supporting, so you're not going to have a respiration rate, but it has the word pressure in it, so we're going to regulate the pressure, and it's not going to have any volume, right? And again, this is like, if it's support, that means they can breathe on their own. So yeah, they wouldn't need a respiratory rate, and that means they probably are spontaneously breathing on their own. So, because again, spontaneously breathing means that the patient is taking their own, they're breathing on their own. Like they're not getting triggered by the vent to breathe. So, hope that makes sense. And then a T-tube blow by, you don't even need to know this, but basically it's just, it helps in clinic, I guess, but weaning, ready to extubate, put them on a T-tube. You've seen the letter T, it's a device shaped like that. It just allows for more flow of oxygen to be controlled, and so it's not directly going into the, so with like the vent or like a trach, if you don't have the T-tube or anything, it's just going directly into the trach. So if I'm having a T-tube, there's more of that, I guess, in essence, dead space, and the oxygen is still going through that. So it kind of just allows it a little bit more controlled instead of directly going into that. So again, it's just you're getting ready to extubate them. You wean them off of that. And then again, that's what the blow by is for. It's a method of delivering oxygen without direct attachment to the patient's airway. So that's basically how I would think about it. So again, it makes sense for patients who are uncomfortable with masks. You're literally putting it on them instead of just having them on this thing that's not directly attached to their airway. So you don't even need to know that. It's just more of like, okay, if they're on a T-tube or a blow by, just know that they're doing pretty good. So that's modes. I do not think you have to even know that much. I think you should just know the bare minimum of what that is, and you'll pass with that, because she will. I do not expect her to ask a bunch of things, and if she does, it's usually just going to be about one or two things. My friend said the PCIRV, so that's all you really have to know for but I feel like the IRV one, it's just she's going to ask you maybe about the ratio and what that looks like. Like it's not going to be 1 to 2, right? Because that's not an inverse ratio. We just talked about the normal one is 1 to 2. So it should look like 3 to 1 or something like that. So how do we know when a patient is ready to start weaning? Well, right, we do spontaneous breathing trials to see if they're able to breathe on their own without the mechanically ventilation, right? That's not the same as triggering, because the vent is triggering them to do that. We want to see if they're actually breathing on their own. So they do that. If it doesn't work, then you just put the vent back on and that's it. And they do that throughout the entire time. So yeah, and then obviously if they're getting better, if they came in with sepsis and then obviously they're having organ dysfunction, now they have ARDS, we're going to put them on pressure control or whatever, right? Because we don't want to really just go for volume control because of the barotrauma risk of popping the lung. So we do that. We see where they're at. Oh, their temperature's going down. Their WBCs are going down. Seems like the medications are working. Seems like all of the rest of their organs are working pretty fine. On their x-ray, it says that we're not showing those opacities anymore for ARDS. So now maybe we can probably suggest for the provider or the RT to look and possibly consider a spontaneous breathing trial, right? So that's how you think about that. She won't ask that, but I just think like that's how you think about it, like in a real life setting, right? So the wean screen, she told us to know that. She did not ask us anything about that. I'm gonna be so for real. I feel like that's just straight up memorizing those values. So if you have to memorize those things, go for it. But again, we're just looking for that they're hemodynamically stable. Because again, we're wanting proper perfusion. We'll get into hemodynamics next week or whenever she goes over it. But really, again, we have like the hemoglobin that's part of the RBCs. We want to make sure that those organs are being properly perfused, which I talked about last week with like the ANP of like the intrapulmonary shunt, the BQ shunt, understanding the difference between ventilation and perfusion, right? Because you need both. Adequate muscle strength, right? So if they don't have the strength to breathe on their own, if they're feeling very weak, and I feel like that's makes sense. Like when you have the flu, when you have a fever, you just feel like you feel very heavy and you feel like you're just short of breath because you're having to work extra harder, right? So having that and then making sure that those values like the PaO2 FiO2 ratio is within those things, then we can start reading them. So really just keep writing the values down, memorize that. Straight up memory, that's it. But honestly, she did not ask us about that, so take that as you will. And then for the graph, I went over it last week. We'll go over it in a second. And then all you have to know is those mechanically ventilation indicators, right? Normal values, you should know those things, right? So 35 to 45, PaO2 80 to 100, and the pH 7.35, 7.45. So obviously we're already at the point for ventilating if they're way below that, which is 7.25, if it's CO2 above 50, right? Usually 35 to 45, PaO2 under 60, right? So usually it should be 80 to 100, and then the respiration rate 35 or above. Usually the respiration rate should be again like 12 to 20, 12 to 24, based off of whatever she tells you. But if you see those things, time to intubate. And she most likely will give you a question where it's straight up just selectively apply which one would be an indicator to ventilate, which I think I asked last week, but on the practice question sheet. But that's basically all you have to know. She also told us to know the endotracheal tube sizes, but I think that was more for a clinic. But yeah, adult size is 7.5 to 8.5, 14 days or less for that. And complications, I feel like it makes sense. You're going to have trauma, you can have hematomas, a fistula. Oh, but that makes sense, like narrowing because it's inflamed. And you'll see that when you start going into, I think, clinic, because sometimes people are intubated, then they start pulling on it, especially if they're ready to be weaned off. So one of my patients was ready to be weaned off of it and was doing totally fine, but kept like making themselves gag and vomit things up. And we tried to tell them to stop. And I even said, like, we got to get her on some type of nausea, vomiting medication, Zofran, something, just because the problem is that since she kept trying to make herself gag, her throat and her airway got super inflamed again because of all of the pressure, and we had to intubate them again. So those are things, I guess, that make sense with an endotracheal tube. Trachs, it's just more long term for that. It's you're able to still suction them, do what you can, and sometimes it's just needed if they have issues within some trauma to their face, anything like that, and you just want to go straight to the trach, which is fine. But again, that's what it is. Medications, those things, just read it. She doesn't really expect you to know, and I feel like you kind of already know these things, right? Like corticosteroids, what are the side effects for that? The GHATs, right? That's pretty much all you have to know. Antibiotics empirically, so they're given before the cultures, sedation. So again, just look at the conscious sedation meds. We'll talk about that stuff when she gets into the end of the ARDS lecture next week, about sedation and all those things and what we're supposed to do and why that makes sense. Analgesics, right, to make sure that they're not going against the vent, that they feel comfortable, right? It's not normal to have something in your airway. Transfusions, hemoglobin, if they're bleeding, if there's any type of issue. Neuromuscular blockers, again, for paralysis. Paralysis decreases the O2 demand and how you're working. When we talk about the hemoglobin shift, remember, we're kind of helping out with that and making sure they're not overworking. So I hope that makes sense for that. But really, that's all you have to know. Like, it's pretty basic stuff. She won't ask you this stuff. She might just be like, what can we consider giving to the patient? But I feel like all of these things make sense, right? And they're pretty easy to know. Assessment, those things are, I feel like, pretty obvious to kind of point out. And then VAP, I don't even think you have to know this. She didn't ask us anything about it, but it kind of makes sense, right? It's super short. Basically, you get intubated. Okay, now you have colonization of bacteria, of a lot of things, and now you're gonna have some aspiration. Okay, and then you have pneumonia. So that's why basically we remove the secretions. So it's okay to suction them, especially if they're coughing a lot. It's okay to do that because we don't want them to get back into their lungs. You can elevate their head of the bed, right? If we lay them flat, you have a higher risk of those fluids being able to go into the trachea, to go into the lungs. And then obviously making sure you're washing your hands. Of course, always washing your hands, keeping things sterile or free of bacteria, just because, again, you have that risk of getting an infection all the time. So kind of basic stuff. And then the very last thing, I'm just going to go over the first one. So this is how she would do it. So how do I know? I guess the question is, okay, Genesis, how do I know which is what? Like if she doesn't say the mode is this, the rate is this, the tidal volume is this, how do I know what's what? Well, remember we talked about it, right? So assist control, okay, that one's ACVC, volume, most of them have respiration, like respiration rate set, so it does. It's volume control, it's also called AC, VC, so volume control, no set pressure, but there is a volume. So this is the full vent support one. So, okay, well, remember the normal rate should be between, respiratory rate should be between like 12 to 24, 12 to 20. It's at a 12. So, that one should be fine. The volume, 50 mLs. Well, it says mLs and it's, or sorry, 500 mLs. Um, volume, remember, should be in mLs, but even if she doesn't give you the mLs, I feel like it makes sense. It's a huge number. It wouldn't make sense if the rate was 500. It wouldn't make sense if the FiO2 was 500%. And remember, FiO2 has a percentage, so it's easy to remember. But the volume, mLs, even if not, it's going to be probably a big number. FiO2, percent, so you're going to see a percent. She doesn't give you a percent, she will. But if she doesn't, it's like, okay, you shouldn't be setting the rate to 40. You shouldn't be setting the tidal volume to 40 because usually it should be a very high number. Okay, and then with PEEP, usually she'll put a +5 in the front of it. Usually, again, the value is 5 to 20. You don't have to necessarily know that, but if you do know that they're on like a 20, just know that that's kind of worse, right? You kind of usually see them at 5s, usually. But if you see them at like a 20, that probably means that they're not oxygenating well. So PEEP, a 5, you see that. It's going to be low, so usually that makes sense. The rate wouldn't be 5. The FiO2 doesn't even have a percentage, so it wouldn't be that. And the tidal volume being 5 mLs would be crazy. So I feel like that makes sense. Like if you were to cover it up, and you can practice that, just maybe get like a white marker. You need to print this out, or I can send this like through the electronic stuff. If you were to put this in white and cross out each thing, just label it. Try doing that. I have it set like this because usually she will give it to you. But if she doesn't, and throughout the semester, I wouldn't be surprised if she just goes ACVC 12, 500, 40% +5. But again, PEEP has a P in it, so there's a +5. She doesn't give you the +5. Again, it's a smaller number. Even if it's like 20, usually the rate is going to be first. But again, don't worry about those things. She will probably give it to you. And if she doesn't, it's pretty obvious when you look at it. And then in the question, it's usually a select all the apply. So then it's like, okay, increase the rate or increase the respiratory rate from 12 to 24. So they give you that answer, like she gives you the answer of which one's which in the question. But practice that if you're not understanding that. So really with this one, she would also give you the bicarb and either the SpO2 or the SaO2. But really, again, if you were to think about the PaO2 or FiO2 ratio, you would just look at the FiO2 and the PaO2, right? For the hypoxemia. But because at the beginning we're just talking about changing the vent settings, basically you're just going to look at CO2 or O2. So in a question like this, look at the FiO2, PaO2, do the math for the ratio if she's asking it on the question, or if you see it there within the selectively apply, like moderate hypoxemia, right? Sometimes she'll even put like, it says like severe, but it's mild, but like there's not another option to put mild hypoxemia, then don't select it, right? Don't try to look for another answer or put in another answer. Sometimes she just does that to kind of like trick you or kind of throw you off. But if it's not that, don't select it. So the other thing with that too is that CO2 or PaO2, you're just going to look at it. Okay, so we know that the regular, you don't even need to look at the ABG unless you're doing like a metabolic acidosis or specific term where she's like making you write it in and you have to put what ABG, acid-base balance, it is. You're not going to do that. All you have to do is the CO2 or the PaO2 in terms of vent changes, right? So normal range, 35 to 45. Well, obviously with the PaO2 or PaCO2, sorry, is high. It's at 58. Okay, PaO2 should be below, if it's below 80, that's abnormal. So it should be within 80 to 100. If it's above 100, that means they're over oxygenated. But this one's 85, so I feel good about that. Don't need to look at the bicarb. Don't need to look at the other values for that. So for this, I know that because they're having a high CO2, right? They're having a high CO2, and then the acid goes with it, like the acid-base balance, right? Because if you look at the pH, it's 7.28, which means that it's lower than 7.35, which means it's acidotic. And CO2 is an acid, so it's high. So if you wanted to like confirm, you could do that. But really, all you have to do is just draw an arrow and be like, okay, it's high. So because of that, really you know that that means that they're hypoventilating because they're retaining everything. If I'm not breathing, and I've talked about this 50,000 times, so if you have to do what I do to think about it, that's totally fine. If I'm not breathing, I'm keeping all that CO2 in, right? Because remember, if I'm exhaling, I'm letting go of all that CO2. So I am hypoventilating with this. And that's what's causing me to increase the CO2, causing my pH to go down because it's acidotic. And CO2 is an acid. So the things that we can do, and I feel like this one makes sense, the respiration rate is going to increase. Because again, I just said if I'm hypoventilating and I'm not breathing, I'm not having a faster respiratory rate, I'm having a low one, I'm retaining all of that CO2 in. But if I increase the respiratory rate on their vent, that's going to cause them to breathe it out more, right? So that's why you do that. That will decrease the CO2. The other one with that is the tidal volume. So that's the amount of air that I'm giving, right? So why would that make sense? Why would that not go with oxygen, PaO2? Well, the reason why is because you're giving more volume of air. So the amount of CO2 goes down because you're putting more O2 in allows for more of that O2 to come out. So the other ones, when you're talking about FiO2, you're talking about the actual concentration of oxygen. So of course they're going to get more concentration of oxygen through that. Tidal volume is not the same as concentration. That's just the amount of air. So if I put more air into my lungs, something has to come out. So that's going to be CO2. So you have less CO2 because of that, because more O2 is in. And then PEEP. PEEP is not necessarily allowing more O2 in. It just allows for better oxygenation, remember, because you're keeping the airway open for longer. So that's why tidal volume and respiration rate are together. If you have to memorize it, then memorize it. Okay, so that's why the tidal volume would be higher because we want less CO2, so we're gonna make O2 a little bit higher by just increasing the tidal volume. More air goes in, so more O2 gets out. So it's not necessarily the concentration, but you're changing that CO2 by coming out because more air is physically coming in. So I hope that makes sense. So the rest of the answers are right here. So I'll just leave this up here because I'll give you guys a blank sheet. So that makes sense for that. And then I put the chart there, but just know when I send this out, it's going to be completely blank. It's just going to be the questions. Another thing, if you do not understand this at all, okay, the last thing is I try to make it like simple to where you guys can understand it. Also, I went over time, but that's fine. But the one thing that you can do is you just, if you have to memorize it and you just truly don't understand it, that's okay. I understand. So just remember, you just would have to memorize CO2 respiration rate, which I feel like makes sense, and then the tidal volume goes with that. Then you would remember the other two goes with the other one, right? So I feel like that's easy to remember. The other thing, in terms of the way that the arrows are pointing, okay, so with oxygen, the arrows will be pointing opposite. So O with O, right? So if I'm looking at CO2, so for the next question, it's at 30, which means it's below the point that it should be, right? So since it's below the 35 to 45, so I know that it's down, and I know that that one has respiration rate with CO2, and that one has tidal volume. So the arrow should be matching for the CO2. But if you look at, let's say, the O2, again, remember CO2 has the respiration rate, it has a tidal volume. PaO2 would have the opposite, so FiO2 in the PEEP. So PaO2 is at 55, which means it's super low. So the arrow is pointing down, which means your FiO2 and your PEEP would be pointing up. Because again, with oxygen, the arrows will be pointing opposite. Whereas with CO2, they should be pointing in the same direction. So really, if you, worst case scenario, if you're not understanding it, you just need to memorize that. That's what I would recommend. And then for the very last one, with increased FiO2 and PEEP, and then they both are increased, actually, respiration rate, tidal volume, all of those things. If it says PaCO2 of 50, you do one step at a time, right? So then the arrows match respiration rate, tidal volume, PaO2 is down. So then we're going to increase the FiO2 and then the PEEP with that. So that kind of is another way that you can think about it, and how I was trying to think about, like in case you guys aren't understanding that, what's like the other case scenario that you can do if like you're freaking out or anything like that. So I'll send that out so you guys can practice that. And then here's the FiO2 PaO2 ratio. I feel like that one's pretty simple. And then again, you could also do the PEEP and the FiO2. You can do that chart with these questions as well. But other than that, that's pretty much it. I'm trying to think of something else that I was trying to think of earlier that I was like, oh, I should probably tell them this. But I think I mentioned everything. Oh, yeah. So for this question right here, if this was an ARDS patient and I wanted to increase the tidal volume because their CO2 is high, my answer would be don't do it. Just because, again, we don't want to have that risk of barotrauma, right? So I'm just going to increase the respiratory rate, increase the FiO2, and increase the PEEP probably. That might be a question that Mandiola can answer, but I feel like on the exam, she put that on there. And because I was like, well, you shouldn't really be giving them volume, I didn't put it on there. And I'm pretty sure I got it right. I tried to write a lot of questions down after the exam, and it also is helpful because it's like I tried to remember the things I got wrong and write it down because I also was like, for the final, a lot of these things are incorporated and throughout the rest of the exams, right? So I'll check that out and see, and I might talk to some of my friends about it and see what they put too because I can't really remember. But most of the time, I feel like again the whole point is that we would rather do PEEP and FiO2 because of the oxygenation. It's more of a hypoxemia issue rather than a CO2 issue. So we can, yeah, increase the respiratory rate with that just to help them out because they have a CO2 that's high, but I don't want to cause them to have barotrauma and then pop their lung or give them a lung injury because, again, it's ARDS. So something to note with that one. But other than that, I'm going to stop sharing my screen. And that's pretty much it in terms of vent modes and everything like that. So I hope that helps. But other than that, if you guys have any more questions, you can stay in here and I can help answer that. I'm going to stop recording.